Health's primary care champion for tobacco control, i.e. he's the ministry's go-to guy for primary care and helping our people stop smoking. John is also a practicing GP in Whanganui and clinical director of the Whanganui Regional Health Network. I'm also running on the assumption most of you can read and you can see his profile in the pack, so I'll leave it at that and hand over to John.
Kia ora, Eugene. Morena koutou. Kia ora to Grace and Yvonne for really a very humbling presentation. Wish I went first actually, because I always feel when you go after such a moving presentation it's quite difficult, especially because this might be perceived as perhaps on the slightly drier side of a presentation. So I'm a GP in my day job, and that's primarily my main work, as well as working in a mainstream practice which has to struggle with all the same issues that all other mainstream practices. I have a very small clinical director role in a high needs VLCL practice, which has 6,000 patients in a very high needs area in Wanganui, and we are struggling there with all the same issues that everybody else is struggling. I work with the Wanganui Regional Health Network, which is our PHO, chairing the clinical governance there, and in that role I'm responsible for the quality around tobacco. So that engages me visiting a lot of practices and talking with doctors and nurses about the target, but really about the reality of how do you engage with tobacco there. And as a result of that kind of background, I've been working with the ministry, just again very part-time, supporting the tobacco team, looking at the primary care involvement there, and as a consequence of working with them I got kind of sidewayed into being the National Tobacco Target Champion, so kind of responsible at lots of different areas, and that's been a really interesting process because I'm engaged clinically in smoking cessation, but I'm also engaged organisationally as well. Really just to touch base with where we're at around Māori and Pacific smoking. The most recent prevalence data is from 201415, and for Māori over the whole country we have a prevalence of 38%. You can see that actually it has come down a little bit, and this disguises actually a large number of quits, because of course this is a prevalence figure, and so it includes everyone who's taken up smoking, and this is a real issue in an area where there's high prevalence of young Māori, because you can be very successful at helping people quit, but this is the group that are taking up smoking, and so it impacts very negatively on the prevalence. So one of the things that we need to name is that, as well as helping people to quit, which is essentially what the Stop Smoking Service is all about, we need to be thinking about what's our role in helping people not take up smoking in the first place. For Pacific, figures are slightly lower, and again, there's a little bit of movement there. But as you can see, for Māori and Pacific, the burden of smoking-related illness and death is very inequitable and very inequitably borne by Māori and Pacific. Just out of interest, we are seeing people in general practice. So for the total population, the data shows that we see 80% of people in a year. For Māori and Pacific, we see in the 70%. So even though this is not obviously 100%, there are lots of opportunities, and this is the basis for a target that relies on a clinical interface. So when the target first came about, it came about as a general practice target, and the reason for that was because that's where the evidence was. The evidence was that doctors giving advice to stop smoking was successful, and so we had that as a target. Then the evidence shifted a little bit, and the evidence is now not giving advice to quit, but actually offering support to quit, which is a bit of a shift in the thinking, and we know that that's very successful. And then the target, then what happened was that because we effectively supported the GP target with primary health organisation and population focus, we found that you could actually achieve a lot supporting clinical people by providing other options and other ways of contacting people about smoking. So the target now obviously has shifted to a population-based target and represents all the smokers that are enrolled in a population, being 90% of them being our goal. And that's a really good thing, because it's taken the direct onus off the clinical people and saying it's not just your job, it is your job, but it's also other people's jobs as well, which is great. You'll appreciate that in the stop smoking guidelines, there is a just get this on. Oh, sorry. The lower graph here is the abstinence rate by treatment methods, and that's a really available graph. The interpretation of that being that if people try to quit on their own, they're likely to be pretty unsuccessful. And if they quit with support, with NRT or medication support, the likelihood of them having a successful quit improves. But if they have support, behavioural support along with the medication, then the likelihood is that they're very much higher success rate. So there's a formula called the first law of smoking cessation, which some of you may have come across. This is from the UK, Professor West. He's a colleague of Hayden McRobbie's there. And although it's a very self-evident equation, it bears a little bit of thinking, because this is what we have to do. The number of ex-smokers created in a given time is going to be related to the number of smokers who try to stop and the probability of success in those who stop. And if you think about what the primary target has been up to now, we've had lots of people being offered brief advice with a borderline relationship between that brief advice and actually engaging in smoking cessation, and then a not a very good link with the actual stop smoking services for many practices. So the probability of success is quite low. So we are currently talking with smoking every year with 86% of the smoking population. So it's not that the discussions aren't being had. So why isn't that translating into way more quits? And it's because of the lack of quality around the two processes here. The number of smokers who try to stop, that process of asking them needs to be shifted into some kind of effective outcome. And then probability of success means that you actually have to have successful quitting for the number of people that are stopping. And I just want to go through that a little bit, because it implies that we need to think then about how are we recruiting people for smoking cessation, how are we matching smokers with the best option for cessation, and how do we actually ensure behavioural support. So for those of you that are involved in stop smoking services, you're already engaged in this, but in mainstream practice, many practices don't have a direct access to this other than a quitline referral. And so you can see that, important though that quitline referral is, for many of the practices, this is not integrated and effective. So if we just think about how we do recruit, I just want to think about it from a clinical perspective and then from a PHO perspective. So from a clinical perspective, obviously it's about offering cessation support. This is part of the patter of a clinical interchange, and we should all have this off pat, really. And anybody who says they can't take 30 seconds to raise smoking needs some training around this, because it's very easy to raise the issue of smoking. And people just need to have a simple way that they raise it and get it on the agenda. We obviously need to then be looking at how do we offer cessation support. So it's not just about giving brief advice, but about the way in which we word that, so that we encourage our patients to have an expectation that we want to support them. And this is the aroha concept and the whānau concept that we talked about before. It's about responding to that person in what is an appropriate way that's going to get some engagement. We need to look for clinical opportunities. And there are loads of clinical opportunities, and there are a lot of clinical opportunities that have myths associated with them. So yesterday I saw a mum with a baby of about 8 months who was a little bit wheezy, and I know she's a smoker. So after dealing with the child, I said, can we just touch base about the smoking? She says, oh, it's okay, I smoke outside, you know. And when we've heard this so many times, you know, in fact, some people have smoking jackets, they smoke outside. And I said, can I tell you some information about smoking outside that you may not know? That what's important for your child, what's going to help that child's respiratory problem is not getting exposed to the little particles that you will have on your clothes, that when you come back in, these are all going to be floating off and your child's going to be exposed. And that was a new bit of information for that mum. And for the first time, she said, well, maybe I need to look at that. She wasn't really on the spot. I need to do a follow-up with the child, so I've booked the child for a follow-up and I've booked her to come back and have a discussion. And we've named that as an agenda item for the next follow-up. When you look at the number of people that come into a practice who don't get asked about smoking, and many of you will have access to audit tools that do this. So the one that we use in our practice is the Doctor Info tool, and you can identify who's been in the practice in the last 3 months, who is overdue for smoking and didn't get asked. And when you go and actually look at what that was, many of those people actually came in with respiratory consultations or consultations where smoking was actually directly relevant. And it's good practice for us to be engaging with smoking and a discussion around smoking for clinical issues that is actually part of the process. So it's not just the asking out of the blue. There are loads and loads of clinical opportunities, and perhaps we've underestimated how we can encourage people to use those clinical opportunities. Expecting smokers to want to stop, and I mean Grace's video, I've seen it a few times, and it really echoes with me. Apart from the messages on that video, we know from surveys that in any given year, at least 1/3 of smokers will have a serious 1-week attempt to stop, and 2/3 will have more than one. So if you happen to get the person at the time that they're stopping, then that's going to be very successful because they're right at that point. And this is one of the drivers behind the idea of texting out and so forth, is that you just might happen to get that person at that time. And then setting up quit plans or quit by dates. So one of the things that's easy to do, smokers are like all patients, you know, if there's something difficult they don't want to do, they'll try and kind of slide off that and, you know, they'll kind of move aside, and they're very skilled at, no, I'm not going there with you, doc. Okay, you don't want to do that today, but can we do this? Would you be interested in stopping at some stage? And if people then say, well, I'm thinking of stopping next year, or I'm thinking of stopping on my birthday, then I'll put a reminder in the system to say, let's contact you on your birthday. So we just need to kind of step up and seize those kinds of opportunities that are out there, and not make the assumption that just because people say no, that they actually don't want you to support them or encourage them. Beyond the practice, because it's not just a clinical target, what needs to happen with the PHOs? What do we need to ask from our PHOs? Clearly, we need to be texting smokers. Now, this does depend on the accuracy of phone numbers, and I'm as aware of anybody else that sometimes it's cheaper to buy a new phone than it is to get another SIM card. And so some people change their numbers all the time. But behind this texting process, we have to have an engagement of reception and an understanding of their critical role in smoking cessation, that every contact with a person, they update the phone number. And that needs to happen every single time. Once you've got that, you can significantly increase the number of successful access to people. Of course, that's not going to solve all problems, and I have got an answer for that question that came from the table before that may be useful. We need to be thinking at the PHO level, and maybe to a certain extent at DHB level, about special groups, obviously pregnancy, obviously mental health patients. It's very hard for a clinician on their own to help someone stop smoking who actually needs a lot of support. And what we find when we do this is that if you have someone who's pregnant and you refer them to the pregnancy service, or if you have someone who has long-term mental health problems and you try and engage them in smoking cessation, what tends to happen is it falls off somewhere, and it falls off because we haven't got it joined up well enough. So in general practice, we've got to join our special needs situations up very carefully with the stop smoking services, and we've got to have that closing the loop concept that we have in so much else of healthcare, that if someone is referred around pregnancy. If someone is referred into stop smoking service for long-term mental health support, do I know that they have actually attended, and do I know whether they're engaging? So it's about attention to detail, and at the practice level and at the PHO level, we need to name this and increase the professionalism around the way in which we organise our services. Incentives for quits. As you were aware, stop smoking incentives for pregnancy and sometimes for youth services exist, and particularly for pregnancy, they do seem to be very effective in some areas, and in some areas they've been extremely effective. So that is something that a PHO or a DHB needs to step back and address and say, what kinds of incentives can we offer people? Peer and auntie recruitment is just that process of recognising that the actual recruitment of people isn't always going to be during their attendance at the practice. So PHOs are quite often engaged out in the community. They go to workplaces. They may have days that they have stands at, and there's lots of ways in which they are out there in the community. And I think the answer to the question from before is a new tool which we're actively working on at the moment. So it's a kind of watch the space tool, but I think it'll be very successful. And this is a tool that can interrogate the practice information out in the field and let you know whether that person is due for smoking. Because one of the problems that you've got is that you're engaged in activities in the community, and you've got a person who that you're dealing with, and because you don't know what their relationship with their practice is, often you don't know who their practice is, you don't know whether they're overdue for being asked about smoking, and if we can have that kind of information, then that would make obviously a big difference, as well as updating their current phone number at the same time. So we're working on a tool that's going to be able to address that issue and enable us to use these community opportunities and link them back into the practice. The idea of the auntie recruitment is a bit variable. The bottom thing I've got there about cost effectiveness and efficiency is important, because some of these ideas sound really good but may not be good. So we do need to be critical about if we use, say, for example, auntie influence to influence young people, in fact, is that successful? And in some situations it is, and some it isn't. And we need to assess and be ready to change if that's not successful. But in many areas, they have engaged not just with peer support, but with whānau support, obviously, as well. And that's on the recruitment side, as well as on the actual management side. And then linking with other activities. So that's... no practice is going to lead that. Practices are head down, they're just focused on the clinical work. Someone needs to look at these opportunities that arise out in the community and maximise what those opportunities are. So you can see that for recruitment, we've got partly what's going to happen in the practice, and we really need a much more professional practice approach to this, but we also need a lot of backup support from PHOs and DHBs to support that whole process. Effectiveness of quitting. This is a graph that shows the amount of NRT per month, so 50,000 units of NRT going out every month. Down the bottom is medications, next to none. So we've got it around the wrong way. The most successful quitting process is prescribed medication along with behavioural support, and yet we are not doing that. So we need to come back and look at what has to happen for practices to start prescribing more. Now, we do have to be careful around this, because it's not just about prescribing, it's about prescribing effectively. For example, for Renaclean, which is a 3-month course, only a third of people finish the 3 months. And that's not primarily because of problems with the medication, it's primarily because there's inadequate follow-up and contact with the people who have been started. So we need to have processes in place in the practice that if we're starting somebody on medication, that somebody, it might be the clinical person who's engaged, it might be a stop smoking person, it might be somebody else appointed to that task, somebody needs to contact that person after a week and touch base with how's it going, are you tolerating the medication, what are the problems, are you having dreams, are you having nausea, we can solve those problems, don't give up on this medication, which is the most likely chance that you've got to succeed. And of course that same process leads into the successful behavioural support. We know that we nearly double the effectiveness of medication if we have behavioural support. So you can see it's all about encouraging clinicians to apply the same standards that they do to other medications. I don't start someone on a blood pressure medication and then just say willy-nilly, well, you've got the pills, come back in 3 months or 6 months and we'll see how it goes, you know. I mean, I follow up on it and check that it's actually working. If we're treating depression, you know, it's a high-risk scenario. We follow up closely to make sure the medication's safe and what's happening. But for some reason, we're not applying that same high level of professional standard to stop smoking medications. So we need more stop smoking medications, but we need them in a way that is actually being monitored. And so that probably has to happen at PHO level. We need to be checking who's been prescribed, how many have been picked up, and are people actually staying with it? Because if they're not staying with it, it's not going to be effective, and then that's just actually quite a large waste of money, because, you know, they're very expensive medications. So thinking then about the best option for cessation, for clinicians, there's still nothing wrong with actually prescribing NRT, because many of the people that have used NRT just haven't used it right. And so we know NRT is effective. Some of the prescribed medications are more effective, that's true. But we can still look at NRT, and I believe that in practices we have to have some easy access information around how you use NRT via YouTube and that kind of process, which is all available. Because if people say, well, I haven't got time to sit and go through this entire talk about how you should use it, I mean, not that it actually takes that long really, but okay, well then here's a YouTube clip, you know. So there's lots of ways that we can enhance the use of NRT. And use NRT if there has been prior inadequate use. But we need to offer bupropion and varenicline if the prior use of NRT has been unsuccessful. And you meet the criteria for it. For varenicline, if you've had two goes at stopping, and there'd be virtually no smoker who hasn't had 2 goes at stopping with NRT. Obviously ensure good medication counselling, early follow-up to preempt problems, and active follow-up as needed. So the way that we do it in our practice is that when we are educating people about varenicline or bupropion, we have an outbox document that we print, and that gives them information that we go through with them, so that we've touched on the potential for side effects and what might happen. And that outbox automatically links onto a task list, and the task list is the quit task list. So the quit person has a responsibility a week later going into that task list and seeing all the people that have got started on medication. The doc doesn't have to do anything. All they have to do is actually print the information sheet. The rest of it happens automatically. And then the quit person looks at that list and then makes those contacts. Do you need to come back in and see the doctor? Is it going okay? Okay, now how can we look at providing behavioural support to you on an ongoing basis? So we've got to ensure good medication counselling, early follow-up, and I guess the key thing is it needs active follow-up. It's not something that we can just do. It needs to be actively followed up. And then ensuring behavioural support. So for clinical staff, any clinician that is encouraging someone to stop smoking has to have a simple and easy access to behavioural support. So they've got to have whatever their process is. If it's quitline, they've got to know how to use it easily. The quitline referral document's got a great little box so you can write things, so you can personalise the message. You can tell them what time that you want them phoned. You can say, I'm prescribing, but I just want you to give them behavioural support. You've got loads of options there. It's a very quick referral process, probably less than a minute to do that referral. There are not many other referrals that you can get done in a minute, so that's actually, I think, quite a good thing. And obviously we need to match it to individual needs. So, and I think that's one of the things that, you know, we need to encourage clinicians to be clinicians, and clinical people know and are in a relationship with their patients, and they know which is the medication that's likely to be helpful, and which is the behavioural support that's likely to be helpful. So they know whether a quitline referral is appropriate or a stop smoking service is appropriate, or sometimes you just got to come back and see me because I'm the one that's got the relationship with you, and you're not going to stop unless I actually do the follow-up. So sometimes I've got to do the follow-up. We have to think about how do we match this person with the right kind of outcome. So behavioural support, ensuring access and options are, so in practice, the use of formal practice clinics. So some practices do run formal clinics, and you know that's a very effective stop smoking service. And sometimes they run these services as part of some other services. So one of the difficulties that we often have is how do we find funding to actually fit some activity that we want? So we don't have funding for a stop smoking clinic, but can we do that stop smoking within the framework of some other kind of funding approach? Obviously, Quitline's got a range of services, and we need to be familiar with that. And if people haven't been on the Quitline webpage, they just need to go in there for 30 to 60 seconds, have a bit of a nosy around, and see all the different things that they can do. Because they've got texting, they've got phoning, they've got chat rooms, and they've got emailing. So there's a whole bunch of options that they've got, and you can personalise that for the person and say, what actually would suit you. And then Quit Services, local referral pathways. So I need to be sitting in my chair and have absolute confidence that if I do a referral, all I want to do is print an outbox that's probably going to be pre-formatted. So it's pretty quick. We have an outbox that's pre-formatted. It sucks in any information that we might want to put in there, and we can modify that if we want, and then that goes off to the Stop Smoking service. I know it gets there, and then there's feedback to me about that process. So I'm confident about that process, as opposed to it just going off somewhere and not actually having any specific outcome. This is a wonderful advertisement, isn't it? It's been hugely effective. It was designed as an advertisement for young people, and the Health Promotion Agency did an analysis of its impact on older people, and it was just as effective for older people as it is for younger people. So this is part of the process by which obviously we want to support, actually, we need a divorce here, but also we just need to be thinking about this whole area of how do we actually stop the uptake of smoking, because last year we helped 1,000 people in Wanganui stop smoking. That is, their enrolment data showed a year ago that they were smokers, and then a year later they were ex-smokers. We dropped our prevalence by 100. So there were that many people taking up smoking. It's very disheartening. So clearly, us engaged in stop smoking, this is critical, and we need to be engaged there. But we do have to think about how we're doing that process of helping to stop people smoking. And I don't think that we've adequately explored that process yet. I'm sure that there's a role for general practice in there. Young people, as they take up smoking, this whole video message was about smokers, but you can think aroha and whānau apply just as much to people who haven't started smoking, and we need to be thinking, what can we put into place in practices that will help prevent people from taking up smoking? Of course, that is primarily a job for health promotion, and health promotion is an activity which traditionally is very divorced from general practice. So again, it's about this whole process of integrating. We need to think, how do we integrate health promotion into a practice type environment so that the practitioners are aware of what's happening with health promotion? So in this high needs clinic, for example, at the moment, we're just running a health promotion process that's going to look at having a smoke-free zone around the practice. It's going to involve outreach into local communities where people gather, mainly for educational processes, and try and do recruitment in those processes, and then a consistent approach through the whole practice about how we actually support the message that people need to be smoke-free if they're not smokers. So I think this is a great place just to finish. It's just a good reminder to us that we have got a lot of work to do. We have done a huge amount of work. I mean, we really are up there with nearly 90% of people being offered smoking, but you can see that the quit rates are not actually reflecting that amount of work. And so I think it's great that we've got to that point, but we need then to step up and just, as you can see, professionalise the whole process. And I guess that means takeaway message really is, what can you do to professionalise the processes that you're involved in, whether it's in a practice or whether it's at a PHA level or whether it's at a DHB level. Kia ora koutou.